Bismillahirrahmanirrahim. It's Dr. Abid Rafique Chaudhry, and currently I am working in pediatric ICU at Fatma Memorial Hospital, Lahore. This is a 8-minute PICU chat series lecture, and this lecture is meant for PGs, medical officers working in pediatric ICU, as well as pediatric cardiology or cardiac critical care fellows working in cardiac or pediatric ICU, including nurses. And today lecture is pre-extubation checklist and tips. So before you extubate anyone in PICU, you have to go through this checklist. And although even if you are meticulously plan extubation, still there is a almost 20% failure rate. That means still you can have a reintubation scenario even if you fulfill all these criteria. And once you reintubate someone in pediatric ICU, there is a risk of a ventilator associated pneumonia, prolonged ICU stay, as well as there is a physical trauma to the oral region. So we have to avoid reintubation. But so what things you have to fulfill before you extubate anyone in pediatrics? So the most important thing you have to ask yourself that whether you have reversed the primary disease for which you have intubated the child. So reversal of primary disease for which patient got intubation to begin with is very important. Suppose if someone got shock, and because of shock patient got reintubation, like patient got intubated, so you have to make sure the inotropes they are stopped or they are on the minimal, and patient is passing good amount of urine output. Or if you have intubated someone with status epilepticus, the status epilepticus has been managed well, and patient is fits free. Because mostly what people do mistake, and that is the single most important thing. I mean, you have to make sure that primary disease has been reversed. And obviously at the same time you have to make sure the patient is fully awake and off sedation, and on, or it may be just minimal sedation, because a lot of times we may be like in the last 8 to 10 years, with the introduction of Precedex, dexmedetomidine in pediatric ICU, especially in pediatric cardiac ICU, a lot of times we keep a little bit if someone is on 0.5 microgram per kg per hour of Precedex, maybe you can make it half before extubation, although it does not depress the respiratory drive, and it's a good analgesia at the same time also. So maybe you can cut down to 50% while you are extubating, and later on down the line, maybe after 24 hours, you can fully stop if the patient is pain free. Or maybe you can switch with the IV paracetamol, which mostly these patients they. So you have to make sure, and if someone is on midazolam and like fentanyl, which mostly these patients receive, especially for more than 5 to 7 days, then keep in mind of also the withdrawal problem in these patients. So also they need to have intact protective airway reflexes. That means GCS should be good, and there should be good gag and cuff reflex. Minimal inotropes are stable hemodynamics with the appropriate urine output. That means if someone is on high inotropic sport, then obviously sometime like you intubate myocarditis because of low cardiac output, and they are on high inotropic sport, then we call it that mechanical ventilation is a third or fourth inotropic sport other than your dopamine and epinephrine in myocarditis. So then obviously you have to try to optimize the cardiac output, and you can extubate, but you have to keep in mind that with extubation, if you are taking because left-sided heart lesions like myocarditis, they like positive pressure ventilation. So you have to make sure that patient is able to wean off the ventilator appropriately, because sometimes you have to increase the milrinone in these patients, especially when you are extubating, because once you take off the ventilator, positive pressure, left-sided heart lesions may start to give you a hard time by having a low urine output. So make sure lactate, urine output, and mixed venous saturation is good before you extubate someone. So patient should not be having a frequent secretion, and nurses, they should not be telling you, doctor, this patient has a lot of secretion. So if obviously if someone has a lot of secretion and intubated 5 to 7 days, then you have to keep in mind that if someone is doing every 15 minute like half hour suction, then difficult to extubate patient like that. Chest X-ray should be acceptable for extubation, and someone should have seen the chest X-ray in the morning. A lot of times you see you ordered X-ray in the morning and you can extubate the baby without seeing. So I mean, at least you should have seen that there is nothing abnormal on the chest X-ray. Especially in pediatric cardiac ICU patient, hemostasis is achieved and no bleeding in pediatric cardiac surgery patient. Because if they are bleeding, then obviously you cannot extubate, because a lot of times these bleeding patients you have to sedate and paralyze, because that's the one way you can achieve hemostasis, and they need stable bleeding control before you extubate someone, because after extubation they will be moving more, and then there is a chances of more bleeding. So a lot of times you make a wrong decision and you extubate someone in a patient where still there is hemostasis is an issue. So keep in mind. Also, they should be NPO for minimal 4 to 6 hours to decrease the risk of aspiration. And if you are extubating someone emergency, then try to aspirate the nasogastric. And also for upper airway, DEXA has been given like 4 to 6 hours before, and if they have the leak is more than 20%, then normally we don't give the dexamethasone. I mean, this is the compliance loop, and you can see this is the inspiratory limb and this is the expiratory limb, and this is all this area is telling you that this patient has a significant leak. So patient, if someone has waveform analysis compliance loop on ventilator like this patient does not need DEXA, because that's a leak. Because whatever patient is getting in inspiration, expiration, still it is not coming to the baseline. So this patient can negotiate with extubation without giving dexamethasone. They should have a good respiratory drive and no apnea on CPAP trial. They should not have repeated apnea, and also successfully tolerated 30 minutes of trial of CPI with minimal FI2 like 30 to 40%, pressure support of 10 with pulling out good tidal volume like 8 to 10 ml per kg. So that's a minimal requirement. But normally, if you think the patient clinically is not doing well, although there is a role of blood gas, but we normally rely more on clinical exam. Blood gas sometimes not guide you properly, so I think clinical exam, tachycardia, and increased respiratory rate on CPAP trial is a very good indicator that patient may not be able to extubate. And so you have to decide. You can continue with the CPAP like for prolonged ventilation, or you have to then you should not continue with the CPAP. You should switch to patient SIME, or either you should extubate the patient, because normally we don't give trial of CPAP more than. There should be no signs of respiratory distress, tachypnea, apnea on trial of CPAP. That's again is a more clinical judgment rather than numbers. But if someone is very much tachycardic and is not irritable much, then tachycardia is a sign of CO2 retention and working hard. Then you have to use your clinical judgment. You may not be able to extubate successfully. So there should be no active air leaks, like someone not having pneumothorax on X-ray. You are extubating, so you should see the X-ray in the morning when you plan for extubation. And normally these patients we plan in the evening, especially if you are ventilating someone, for a couple of days. Then plan in the evening, like you have to obviously decrease the pressure SIMV slowly as the patient is clinically tolerating your weaning with the clinical judgment and end-tidal CO2 and oxygen saturation. And your clinical judgment is more important. And I think the most important thing is planning also, because you should not come in the morning and wean suddenly, and then you have more chances of failure in that. And the most important thing, and the last thing, there should be minimal chest wall edema, because a lot of times, especially if someone is intubated for a long time, and they may not have passed a good urine output, and maybe a lot of time they receive a lot of fluids which they should not. Then there is a lot of chest wall edema which decrease the compliance, and there is a risk for re-intubation. So good diuresis, better lung compliance, and sometimes you have to give them Lasix a couple of days before you plan. And if albumin is low, especially less than 2, then maybe albumin is a good idea. Give a good oncotic pressure with albumin and Lasix. I also, especially in small children, sometimes I give them aminophylline before I extubate, although it has some side effect like tachycardia or like the feeding intolerance, but it has good diuretic effects, and also in small babies it prevents from making them apneic. And also, sometimes you have to bump up your inotropes, because you get a good mean arterial pressure, good diuresis, good negative balance is very important, and minimal chest wall edema before you extubate. And I think that's the single most important factor in a pediatric cardiac surgery ICU, which I have worked almost more than 15 years. You have to get negative edema, negative balance before you extubate these patients. Otherwise, they might give you the hard time. Thank you very much.